Tom, with your presentation, video-based presentation.
Well, that was a great presentation. I really appreciate that, Dr. Deepak. I hate to follow it because it was so good. I want to talk about weak zonules, and what I want to do is give some tips that might be useful to people of various levels. One of the great things about the courses in general that Arup puts on is he tends to give courses that have tips for people of all levels, and that's one of the things I really respect about his amazing career of education. And so that's what I want to try to do. I've just got some five tips I want to focus on. So the first one I think is really important and it's kind of subtle, and that's the idea of using a sideways Arshinov shell. So the idea here is we're going to place dispersive viscoelastic in the area of the weakened zonules, as you can see here in this video. And now across from that, we're going to place cohesive viscoelastic, and we're going to use that dispersive the cohesive viscoelastic to jam the dispersive in place. And so now we have a nice protective coating of dispersive viscoelastic, which is wedged in the area of zonular weakness. So this is sort of sideways because the usual Arshinov shell has the dispersive up against the cornea, but now we want the dispersive viscoelastic into the area of weakened zonules using the sideways technique. And I'll show you a couple examples where we use that some more. So the second tip I want to emphasize is that when you're doing viscodissection for an early capsular tension ring, in other words, a capsular tension ring that you're placing when you still have lens material in place, you want to make sure that you don't trap cortical material with the capsular tension ring. And this can be a tricky problem, particularly if you use a standard capsular tension ring as opposed to one like the Henderson ring, which has little wavelets in it. So a standard capsular tension ring can trap cortical material. So the key here is to use cohesive viscoelastic to make a dissection between the residual lens material and the capsule. So the big difference is to use cohesive viscoelastic in this case to get just under the anterior capsule, place the cohesive viscoelastic before you place the early capsular tension ring. And I'll show you some examples of that in just a second. So that's the second tip. The third tip is, and maybe this is obvious to you, maybe it's not, it seems to be a source of confusion, I think, as people are learning, and that is that the capsular tension ring has two ways it can come out. And so it can either come out to the right or it can come out to the left. And so when you ask for a preloaded capsular tension ring, you have to pay attention to this. And so you can see in this box on the right, this is a preloaded Morcher capsular tension ring. You can see it says right on it. And the right refers to which way the capsular tension ring is going to come out of the cartridge. And it's not about the right eye. It's not anything funny like that. It's the way it comes out of the cartridge. And you want to think about this in situations where you know where the zonules are weak. So if you know the zonules are weak on the right relative to your incision, then you want to get a capsular tension ring that comes out towards the weak zonules or comes out towards the right. Now, sometimes you load it yourself. And if you load it yourself, you want to load it in a way so that it comes out in a way that is of best value to your surgery. So keep that in mind, that there's two directions and that you're in charge of how that works. The fourth tip, and this is really important, and then I just want to emphasize how powerful optic capture can be. We talked about reverse optic capture earlier, which I think is really useful, but I'm talking about traditional optic capture where the haptics are in the sulcus and the optic is in the bag. This is a very powerful way to secure a lens when you have weakened zonules, particularly if you supplement that with a capsular tension ring in the bag. So the combination of optic capture with a capsular tension ring in the bag is really a powerful way to secure a lens with weak zonules. And I've been shocked over the years at how useful this can be and about how much zonular weakness you can still have with this technique holding the lens secure. So the idea, of course, is you're gonna put the haptics in the sulcus, you're gonna prolapse the optic posteriorly into the bag and secure the lens. And I'm gonna show you some examples of that in just a second. There's no adjustment needed for the IOL power. The optic is very close to the effective lens position of being planned for the bag. And so there's no reason to worry much about the optic, the power of the optic. So here's an example that shows a couple of those tips. So you can see there's an area of weakened zonules on the left there. We're going to do the sideways Arshinov shell where we place the dispersive viscoelastic first. Now we're placing cohesive viscoelastic, and we're going to jam that dispersive viscoelastic into the area of the weakened zonules. Now we're going to make our rhexis, and we're going to center the rhexis on the lens, not on the pupil. And now we're using cohesive viscodissection for the planned early placement of a capsular tension ring. We're getting just under the anterior capsule with a cohesive viscoelastic. And now we're going to go in with a left aimed capsular tension ring because the weak zonules are on the left side. We're getting just under the anterior capsule. Oh, not quite there. Make sure you're just under the anterior capsule. Lift up, use that dissected space, and place that capsular tension ring so that it doesn't trap any cortical material. And look how nicely it centers the lens. And really the rest of the case was relatively routine after early placement. You can see we put the haptics in the sulcus and the optic in the bag, and I'll talk about that in just a few more minutes. So that's the basic tips I wanted to show you for that. So here's the fifth and final tip, and I'm going to show you a couple other examples. The use of a Sinskey hook when placing the capsular tension ring can be really, really useful. You can see how this kid got trapped here in this playground equipment. It's kind of silly. All of his buddies are trying to get his head out from this silly place that he stuck his head. And sometimes the capsular tension ring can get into trouble with but I mainly want to emphasize the power of a Sinskey guided capsular tension ring for your surgery. So here's the example I was just talking about, which is analogous to that kid getting his head caught. And I wanted to go through the use of MST capsule retractors, which I really love. These are capsule retractors which are useful for loose zonules. Here you can see the rhexis is perfect. This is one of our residents did this surgery. It was a beautiful job. We're placing these MST retractors. You make the paracentesis more like a 60-degree incision, so it's not as flat as the incision that you make for an iris hook. And we're going to place these and sort of get them loosely in place first. We've done some cohesive viscodissection so that the space between the capsule and the lens is freed up. We're just going to loosely place these first, not putting any stress on the zonules. Just get them in place. And once we have all four in place, then we'll tighten them up a little bit right across from each other to secure the lens. And once you have these four retractors in place, the nucleofractus is relatively trivial. They have a tremendous power. Now we're placing the capsular tension ring in, and you won't really notice at first, but there's a problem that occurs here. The capsular tension ring is going pretty well. There's really not much worry. We don't really have any concerns. We're really excited until we notice this right here. So in an odd turn of events, the capsular tension ring went right through the gap in the capsular retractor. So let's take out the other ones first. Maybe the problem will go away. We'll take out these other MST retractors, just hoping that the problem goes away, but of course it doesn't go away. What we end up having to do is cut the MST retractor to get it out of there. And use very sharp edges here, so we're being very careful. We got that little tidbit there left. We weren't sure whether to remove it or not, but we ended up deciding to remove the little tidbit. And this is our chief resident, Luke Lindsay, doing this removal. I thought it was a beautiful job of using the two hands together. And so anyway, I want to show you a technique that eliminates this risk of sort of running these through the MST retractor. So if you use this Sinskey hook to guide that leading eyelet, so guide that leading eyelet around, and so you can very gently place the capsular tension ring in with very little force on the bag, and you can avoid the MST retractors as shown here. So now I just wanted to prove to you that we really did avoid it. So using that technique, I've never caught an MST retractor. Now these MST retractors come in two styles. One is revised by Dr. David Chang, who's I know a mentor to many of us here. And basically what he did was he squeezed it together so there's no way a capsular tension ring can go through the opening. The disadvantage of the Chang technique is it doesn't have as broad a coverage of the equator of the capsular bag. So I still honestly like the standard one a little bit better, but the Chang one eliminates that problem. The Sinskey placement of the capsular tension ring is also useful in cases like this. You can see there's really loose zonules here. We're able to wrestle the lens out of here, but we've got very loose zonules. So we're placing viscoelastic, and now we're going to place the capsular tension ring, and look what happens. It catches in a fold. The bag is so loose that the capsular tension ring catches in a fold and really begins to cause more harm than good here. And so we really are getting a lot of force on the capsular tension ring here as it tries to go in this very loose bag. Look at how the zonules are actually weaker right across from the incision. So now we're going to just do the exact same thing, but we're going to use this Sinskey guided technique. And you can see how just by guiding the capsular tension ring with a Sinskey hook, how much more gentle the insertion is in this exact same case. And now we're able to place a lens in the sulcus. I just want to show you this lens here going into the sulcus. And we're going to do this traditional optic capture where both of the haptics are in the sulcus, but we're going to place this optic into the bag. So you usually tuck half of it in, remove viscoelastic from below. And sometimes, though, I'm just going to show you, sometimes it actually takes two instruments, two hands to get that in the proper position. You can see I'm using two instruments here now, one to push down a little bit and the other, the Kugelin, to lift the capsule up over the optic to get it into the final position. And this lens was remarkably stable given how loose that bag was just a few minutes ago. So this particular position with the haptics in the bag and a capsular tension ring in is very, very powerful and stable. And now I'm going to show just one more case. This is a placement of an early capsular tension ring. And I just want to emphasize in these cases how useful it can be to have, to use soft prolapse. There's a gap right here. You can see there's a gap right here. The zonules are really weak. Now we've already stained, but before we stained, we didn't protect that area with viscoelastic. And so one of the things you're going to notice is trypan blue snuck around there and ended up sort of ruining our red reflex because trypan blue got through that stain because we didn't use that initial viscoelastic for protection. So you can see we have a very poor red reflex here because we've had trypan blue, which has gone around. But here we're placing an earlier capsular tension ring. We're using that Sinskey technique. And you'll see that the lens is actually reformed a bit. The capsular tension ring is all the way out to the equator of the lens, but it's a long-standing defect there, and so the lens has a little dent in it, a little bite out of it. Oftentimes, these traumatic cases like this are very soft lenses, and one of the techniques that I like to use is just to prolapse the whole lens up with a bunch of hydrodissection and hydrodelineation. And then you can go in often with your IA unit underneath the soft lens and remove it. So these soft lenses often are associated with, these zonular problems are often associated with soft lenses. In this case, we're just placing a single piece of acrylic in the bag. And there's nothing too exciting about that. The point on this, you can still see the trypan there in the red reflex. And that's because we didn't seal it off before we started the case. And so the trypan blue is still a little bit evident there. There really wasn't a lot of trypan blue when we saw the patient post-operatively later that day. But it made the case a little bit more tricky. So in summary, I think the sideways Arshinov shell is a very useful technique. So the idea with the sideways Arshinov shell is you put the viscoat in the area of the weak zonules, and then you put cohesive viscoelastic on the other side, and you sort of wedge that dispersive viscoelastic into the area of weak zonules. It can make the rest of the case a lot easier. More and more, I've found going myself to an earlier placement of a capsular tension ring. And in order to do that safely, you want to make sure that you don't trap cortical material when you place the capsular tension ring. And so I like to use cohesive viscodissection, place cohesive viscoelastic just under the anterior capsule, place the coast viscoelastic before you place the capsular tension ring, which goes just under the capsule, of course. The traditional optic capture is really powerful. So have that in your bag of tricks, especially traditional optic capture with the capsular tension ring in the bag. So you have the capsular tension ring you place in the bag, then you place both haptics in the sulcus, and then you prolapse the optic back. No need to adjust the power. And finally, I think you need to have a way to guide the capsular tension ring that doesn't cause iatrogenic trauma to the zonules. And I really like this technique of a Sinskey hook or a small hook to guide the leading eyelid of the capsular tension ring into the bag. It's a useful technique. The way I would suggest you learn that is to first practice on cases where you don't need it. In other words, to use this technique when the zonules are pretty good, but you just need a little bit of a capsular tension ring, and so you're not as dependent on it, because at first it's a little bit tricky to get the two hands together. On the right here, I'm just showing a video in this cataract surgery website that we have. I just wanted to emphasize how useful simulated eyes can be for practicing things like this. And for those of you that are learning, or those of you that have downtime from this horrible virus, you may find that you've got some downtime to work in your own operating room. The great thing about these simulated eyes is you can take these simulated eyes, like there's several companies that have them. The one I'm showing here is from Craig Phillips. And you can take them into your operating room and you can practice. And so you can practice MST retractors, or practice a capsular tension ring, or practice one of Dr. Ahmed's capsular tension segments. You can practice the small instruments that we've been talking about all morning in these simulated eyes in your operating room. It's a very powerful way to practice and get good before you take these patients to your operating room. So thank you, Arup, for inviting me. It's such a pleasure to be in this group. And I also just want to thank Arup for all of your wonderful training over the years to me and all the many residents here in the United States. We certainly appreciate your great educational efforts. Thank you.
Thanks a lot, Tom, for the kind comments and the wonderful videos. The tips that you have conveyed through your videos are really great.